Recording. Thank you. So welcome everyone to today's CIRA talk, Research on the Intersection of HIV and Substance Use. My name is Dini Harsono. I work at CIRA, the Center for Interdisciplinary Research on AIDS at Yale University. Just a very quick information related to logistics. So today's seminar is being recorded for future viewing. So in a couple of weeks' time, the presentation slides and recording will be available at CIRA website. If you are new to CIRA, please visit our website, cira.yale.edu, where you can find a lot of information about our activities, research projects. There's also an opportunity to sign up for our CIRA e-bulletin, which is a monthly newsletter full of information related to events, funding opportunities, and other activities that we support and provide to our affiliates. So today's talk will include two presentations by our two speakers, and will be followed by a discussion and Q&A session at the end. I would welcome everyone to use the chat function to submit questions and comments. And at the end of this talk, there'll be an opportunity for you to complete a very brief survey to have your say about today's talk, and also to inform future events and activities that CIRA will organize. And today's talk will be facilitated by Dr. Jennifer Edelman. She is Associate Professor at the School of Medicine and School of Public Health at Yale. She is certified as an internist, HIV specialist, and in addiction medicine. And her research focuses on optimizing HIV prevention and treatment in the context of substance use, including opioid, alcohol, and tobacco use. At CIRA, Dr. Edelman is the Director of the Clinical and Health Services Research, or CHASER core. And with that, I would like to turn it over to Dr. Edelman.
Thank you so much, Dini, for seamlessly organizing this, and to Pete as well. I'm delighted to welcome Dr. Michael Copenhaver and Dr. Michael Lyons today. Dr. Copenhaver is a professor and licensed clinical psychologist in the Department of Allied Health Sciences at the University of Connecticut. He is also principal investigator at the Institute for Collaboration on Health, Intervention and Policy, or INCHIP, and has an active NIH-funded program of addiction-related research. Since 2002, Dr. Copenhaver has been continuously funded by NIH grants involving the development and implementation of evidence-based HIV prevention strategies. His work emphasizes tailoring behavioral interventions for optimal use in real-world community-based settings. And his most recent work has been focused on addressing PrEP among individuals with opioid use disorder and using evidence-based behavioral intervention designs to accommodate high-risk individuals with opioid use disorder and cognitive dysfunction. I'm really looking forward to hearing about his latest work, a multi-phase optimization strategy to optimize HIV prevention, targeting people on medication for opioid use. He will present first and be followed by Dr. Michael Lyons, who is professor of emergency medicine at Ohio State University. Dr. Lyons is a practicing emergency medicine physician and a professor with tenure and director of population health and health services at Ohio State University, Department of Emergency Medicine. His research focuses on the integration of emergency medicine with public health and other healthcare services, with a particular emphasis on primary and secondary prevention of epidemic infectious diseases and substance use disorders. He serves as co-investigator for the Ohio Valley node of the NIDA Clinical Trials Network and routinely collaborates in other multi-center and multidisciplinary research groups. By working in the Midwest and in multiple different types of emergency departments, Dr. Lyons has been able to facilitate important geographic diversity and development of the national evidence base, and he's received multiple honors. And today we'll be sharing with us his work focused on HIV and substance use disorder interventions in the emergency department setting. And I'm just really thrilled to welcome this conversation and these presentations. With that, I will turn it over to Dr. Copenhaver, and just a reminder to all to please put questions in the chat.
Thanks very much, Dr. Edelman, and thanks to everyone for coming today. I'm going to share my screen, hopefully. And okay, so I will talk about my work, just my recent work that builds off of other work in HIV prevention. This will be a discussion of the multiphase optimization strategy involving people on medication who have opioid use disorder, and also focusing on cognitive dysfunction, a new area that we've started to wade into more recently. So just some background. I'm going to skip through a lot of this because I know that most people are familiar with the idea of the intersection between HIV and opioid use disorder. But they still, people who inject drugs or have some type of opioid use disorder still make up a significant portion of HIV incidence, around 10% still. And the opioid epidemic has really been fueled with people kind of transitioning from painkillers to injecting opioids during the epidemic. So we're still dealing with a pretty significant problem in terms of HIV transmission. Something that isn't discussed quite as much is the comorbidities that many people with opioid use disorder experience, lots of psychiatric comorbidities, but also a significant amount of cognitive dysfunction that impacts how we try to intervene with those people. I'll be focusing on that today. So we know a few things about what works with treating opioid use disorder and HIV prevention. We know biobehavioral treatments are effective when used properly, and so buprenorphine, methadone, naltrexone, lots of different options for medications for opioid use disorder. But they also come along with some degree of counseling and information sessions. And HIV prevention similarly is now taking on a biomedical type of approach, with pre-exposure prophylaxis being a key component of HIV prevention for high-risk people who aren't HIV positive yet, but are on the verge. That also requires some degree of counseling or information sessions. We've developed a really good evidence-based approach called the Community-Friendly Health Recovery Program. We know it works well. And really what we've tried to do is focusing on optimizing this so that it works even better than just what we know it can do. So one of the reasons we've investigated more recently is why these evidence-based approaches, even biobehavioral approaches, don't work better than they do. The effect size tends to be pretty small, even when it's working well. And one of the problems that we've uncovered more recently is that even biobehavioral treatments require some amount of cognitive functioning. So it kind of assumes a level of cognitive processing that may not always be there with many of patients with opioid use disorder. So if it's biomedical, these are things just like recalling to take your medications properly. If it's a behavioral intervention approach, whether it's individual or in a group type of setting, people use executive function, attention, memory, and information processing probably more than we think. And this may be a reason why it hasn't received quite the focus as it's starting to now. And a significant portion of people with opioid use disorder do have mild to moderate cognitive dysfunction. Probably 50 to 60% of our patients demonstrate that level of dysfunction. So not terrible, but also not picking up everything we may think that they are. And obviously not being able to use the information and skills if they're not picking up what we are trying to convey. So one way to organize this that we try to do is just to look at what types of tasks are required cognitively, whether you're talking about individual or group level interventions. And if you look at the components of cognitive functioning, executive function, attention, memory, and information processing, you can organize the intervention tasks that people really need to be doing in the groups that we run, or if we do individual work. Things like talking about planning for relapse prevention or anticipating risky situations. Also learning new information, that's a big one for memory. Interpreting feedback from other people, processing written language. If you put a bunch of information on a whiteboard, are they able to really process and utilize that information in the same way that we assume? And maybe not. So because of that, because of seeing that there's a good amount of demand in terms of cognitive functioning in just the normal everyday behavioral approaches, we really try to borrow from other patient populations in terms of what has been applied to them successfully in the past. So we, with the help of my team, Colleen Missler, she's on, I believe, Roman Shrestha, we've all kind of developed these compensatory strategies to try to accommodate people who have some level, mild to moderate cognitive dysfunction, borrowing from what's worked for people with ADHD or Alzheimer's, even traumatic brain injuries. There have been some creative ways to really try to work around people's cognitive functioning, not necessarily fix it, but work around their ability so that they can benefit as much as possible in the type of information or the type of skills that you're teaching them in intervention approaches, whatever it might be. It doesn't have to be HIV prevention. Obviously, it could be nutrition, education, or whatever it is. We're trying to figure out creative ways to help people who have cognitive dysfunction function optimally. So this multi-phase optimization strategy approach that we've used is pretty different from a conventional randomized control trial in that it doesn't just take an experimental intervention approach we have developed and we think works well and compare it against a control, which a lot of times is just not really much of a comparison. The idea here is that we're trying to really test several different intervention components because we're not sure whether alone or in various combinations what's going to work the best. So this type of design allows us to compare four different types of accommodation strategies in a package. So in order to do that, we provide, you can see in the left-hand column of this graphic that we provide an evidence-based approach content to everyone. But then we have in all the other conditions some combination of one or more of the accommodation strategies that we have previously tested. So that will allow us to look at which maybe only one or two are the important ingredients when they're active that will optimize outcomes. There are three phases in this, in the MOST approach. So the preparation phase, optimization, and evaluation. And we're still kind of early on in what we're doing. In the preparation phase, Colleen Missler, this is part of her dissertation work actually, where she was piloting a single session approach using accommodation strategies. But in order to get to the ones to pilot, she did focus groups with 15 MOUD patients and 10 providers. Really the goal here was to get their input on the examples of some of the ways cognitive dysfunction might disrupt their ability to fully participate in our work, as well as to help us kind of narrow down what some of the most useful strategies might be. So some examples that came out of this were adding significantly more structure than usual to some of the HIV prevention groups or individual work, including mindfulness meditation, using a multimodal presentation or interaction approach in the intervention, and doing lots of hands-on types of demonstrations. So, and this was kind of selected out of a large group of strategies we picked from other patient populations, and these were just examples of some of the ones they thought were more promising that we should maybe try to pilot. So the next step was to pilot those in a single session with 15 patients, all on MOUD. And that was comparing what happens when you only use the content. You don't include any fancy strategies versus a condition where you do include the strategies that we thought were the most promising. And you can see from the graphic that it did pretty well. In a really basic single session test, people who had the accommodation strategies that we tested did significantly better than those who just had the basic content, really one direction of information flowing. There was also a high amount of acceptability in the pilot, so that was also encouraging. So basically they're saying, yeah, we like when you include these ways to help us learn better or take in the information and recall it, things like that. Okay, I'm not going to go too deeply into this, but the next phase involves developing a conceptual model. So again, based on our pilot and based on our secondary analysis of what's worked in other patient populations, we really tried to develop a model showing how we thought this would work. The evidence-based approach that we had already developed is based on the information, motivation, behavioral skills model of health behavior change. So over to the right, you can see how that normally functions across, when you're delivering an intervention that is built on this framework. And what we were doing with the strategies is trying to impact specifically the information component. So how do they take in the information, recall the information, and use it so that their outcomes could be improved, and therefore the theoretical model would show improvement at the end also. So this is our conceptual model. I'm happy to share this with anybody who wants it in the end. Okay, so in terms of the design, the optimization phase, which we're just starting to work on now, uses a factorial design. I showed you the slide, the graphic on the right earlier. So the idea is that everyone receives the same core content, the CHRP content plus being on pre-exposure prophylaxis. So everyone gets that. What we're focused on here is how well different combinations of these cognitive dysfunction accommodation components will impact their outcome, and specifically PrEP adherence, HIV risk reduction, as well as retention in MOUD. So really basic outcomes that we're looking at, and whether these strategies can help with that. In the end, we'll have we plan to have an N of 256. And unlike in a randomized trial, they're divvied up in a lot of, in 16, people per cell in the graphic that you're looking at. So there are a lot of moving parts, but this will allow us to look at, main effects and interactions of components. Maybe only 2 or 3 are the key ingredients if they're active, maybe only 1. Or maybe it's necessary to have all of the, accommodation strategies active at one time to really squeeze the potency out of what we're doing. So just to touch on the inclusion criteria, these are all people at APT. So new patients to APT, they haven't been there longer than 30 days. So they're pretty fresh off the street. They qualify as having mild to moderate cognitive impairment based on the MOCA, a quick screener. And they also have initiated PrEP in the past week. So they're really starting some new, some new individual interventions coming into a new treatment also. So MOUD, PrEP, and that qualifies them to be in this study. They have to have significant risk behavior just to get on PrEP. So they have drug or sex risk behavior. Many of our patients have multiple types of risk behavior. So it's not just like they barely qualify. Many of them have multiple sex partners, also inject, share needles. So there's a lot of risk behavior that we're trying to reduce in these patients, in addition to having them adhere to MOUD and PrEP. So lots of work to do with these high-risk patients. In terms of evaluation, some of the measures I'll just highlight. We're looking at dried blood spots for PrEP adherence, as well as self-report and pharmacy refill data, so we can triangulate those measures. We're also measuring the skills, on the post and follow-up intervention. How well do they know how to properly clean a needle and apply a male and female condom to a replica? So, really, how do the skills come through in the end, as well as the other measures of HIV risk behavior and theoretical measures, IMB measures as well. So we've just started recruitment for this. So this is something that is just starting to get off the ground. And it'll be an interesting time to see how the most framework is going to work for this particular patient population. Never been tried for people with opioid use disorder who are high risk for HIV transmission. And really the idea is to maximize the efficacy of these biobehavioral treatments. And I just want to note also that this has implications not just for this patient population, but other people with cognitive dysfunction. We obviously, if this is working in this setting, we can apply it to other settings and other patient populations and maybe improve other outcomes for high-risk patients. And I will be glad to answer any questions at the end, but that's kind of the gist of what I've been up to lately. And the funding sources I just want to mention are on the first page. NIDA has been really good to me over the past 20 years, and I obviously couldn't have done it without the funding. So I'll stop there.
Thank you for such a terrific talk. I'm just going to remind folks to please feel free to use the chat. We'll take a couple of questions now and then pivot to the next presentation. I just want to ask one question specifically around your talk, and this is terrific work and I think so relevant for probably any medication, right, that patients need to take that have an underlying cognitive dysfunction, right, and opioid use disorder. Right, so HIV meds too, if they have, not necessarily in the context of HIV prevention. I don't know if you want to comment on that. And then my question is whether or not you have someone who has a geriatrics lens as part of your team.
That has been mentioned, and in some of our studies, we have noticed an older patient population certainly making up a sizable group of those who do qualify for having cognitive dysfunction. So I mean, we'll have to wait and see. That could be an interesting sub-analysis, though, to look at.
So I was curious. I think my question probably wasn't clear. I was curious as to whether or not part of your team if you have somebody with a geriatric specific lens, or you didn't feel like that was necessary? It's such a robust conceptual model and design.
We don't. No, we don't have anyone on our team, but we have, the team has looked at a lot of the geriatric literature to try to figure out creative ways to do this. I mean, geriatric literature, the TBI literature, lots of different places. But if you have someone you think we should connect with, I'd be happy for that.
Great. Just one question from Dr. Michael Varada. Was PrEP offered in different modalities, and who are the providers prescribing and are instructing about PrEP use? So I guess the one specifically, is PrEP being prescribed also in the injectable formulation, or are folks only getting it in the oral?
So far, just the daily oral PrEP, and we don't do it. Our team doesn't do it. We let the patients basically pick their provider of choice, and it's Nathan Smith. Most times they have a PrEP navigator we've connected with, and that has been a really helpful relationship that we have going there. But we also have used the van, Rick Altice's team. But yeah, we leave it up to the patient, and that's not, it does make it a little bit more complicated sometimes because we're working with a lot of different providers, but we also don't want to force patients to use someone we think they should use, because that's part of the puzzle, is making sure that they're happy with working with their current provider, or not being forced to go see our doc necessarily.
Makes sense. Thank you. Okay, shall we please continue to use the chat for your questions, and maybe we'll turn it to Dr. Lyons now, and then we'll have time for plenty of discussion and further questions. Thank you so much.
Great, thank you. Can you see my screen okay and hear me okay? All right, very good. So hello, everyone, and thank you for the kind introduction and the invitation to speak today. I wanted to start by explaining, just a bit about why it's such an honor and inherently innovative for emergency medicine to be discussed at a forum such as this, and also why this kind of work is so hard in the emergency department. So it's important to remember that the primary mission of emergency medicine is to provide time-sensitive stabilization, unscheduled care for episodic acute illness and injury. So there's some key consequences that flow from that. And speaking in generalities and broad strokes, EDs are built to be reactive, not proactive. Not only is the ED not expecting you, you weren't expecting to be there either. Emergency physicians are very comfortable improvising and acting even when they don't know what's going on yet. Think Wilderness Medicine or MacGyver from the 80s TV show. Many times I've heard that the first thing that happens in a disaster is you end up throwing away the disaster plan because you're in a disaster. Emergency departments are chronically overwhelmed. The core patient care mission is under threat every single day. And emergency physicians are comfortable making do with less, and they're not really focused on what's ideal. They're just trying to get by and survive. And there's an instinctive assumption that anything new detracts from something else that was previously considered necessary. Every day is chaos, so there's no typical day in the life of the ED. Habits are hard to form. The culture and infrastructure is fundamentally focused on the episode of care at hand, and certainly not a longitudinal view of the patient's life trajectory. And so all of that means that emergency physicians are very comfortable leaving important things undone because there's something else critical that they have to attend to right now. So if something can conceivably wait, it should wait. But there's some other factors to consider. Emergency departments see everybody. We assume that most of the country is either a patient or present in the ED with a patient at least every several years. And we literally see all populations. And that's without the need for any outreach. They come to us, and they come to us in a medical setting where we can do pretty much anything that we need to do. And many of these patients, and in some settings, most of the patients aren't getting needed services elsewhere. And one final thing that's not often mentioned is that after a while, I think many of us start to feel like a hamster spinning your wheel. The work is immensely gratifying, to be sure, but how many times can you see a car crash and not want to stop car crashes from happening, or at least complain to a surveillance system that you're seeing all these car crashes? So beginning around the 1990s, a small cadre of folks began to wonder in earnest if there wasn't a different way we could go about emergency medicine, and to think that research would be needed to find out and ultimately to guide policy. So beginning to think about what happens before the patient comes to the ED and what comes after, and whether the ED could do more than just patch you up and send you on your way, but maybe do something that would be an inflection point in that life trajectory. And we're also beginning to think about individual, not just individual patients, but about populations of patients. So that's a very big idea, and it's still not precisely developed in my view, but certainly even less so back then, and it's still intensely controversial. So we really needed a smaller paradigm to begin whittling away at this larger concept. Now, there's many population health issues that have been worked on, and countless more that we could consider, but arguably HIV and substance use disorder have received the most attention, and I think for good reason. For the purposes of today's talk, I'll note that I think the work in emergency medicine on HIV and SUD has been more in parallel than truly integrated, but I'll provide some examples of integration later and certainly issue a call for more. I also want to just, before moving to this next slide, note that much of the work I think has been in the realm of secondary prevention among people who already have the disease. So more specifically, screening and linkage to care. But there are certainly some of us who are intensely interested in primary prevention as well, and certainly enjoyed the past talk. So moving on, an intimidating amount of work remains before emergency medicine as an overall specialty is really responding in stride to these two health crises. But I think we've made a lot of progress along the way. We've proved that it's possible to do something, and something is more than nothing. We have examples of two complementary approaches, one being co-locating adjunct staff in the ED to expand services, the other changing the practice paradigms of the current staff. We've discovered that we can intervene with our patient population before they come to the ED and after they leave the ED, and that we can even use the ED patient to access their social contacts, so people that are maybe present with them but aren't actually registered as patients themselves. And I think we now have a much better idea of what lies ahead in terms of future directions. So there's no way to comprehensively describe the field or even our own work in the short time today. So what I'd like to do is flash through in some detail the story of HIV screening specifically. We won't touch on other aspects of HIV prevention. And I'll only briefly allude to the parallel story occurring in SUD, but then conclude with some examples of integration between the two. So there had certainly been some seminal research reports in the 1990s, but our story in ED-HIV screening really begins to take off with the first report of doing this on a sustained clinical basis. So, and in this case, this was health department funding of adjunct health professionals that were co-located in the ED and walking around screening people. Because this happened in the Midwest, I think it put everyone on notice that HIV screening wasn't only necessary in large and coastal cities that were the epicenter at the time. And then we compared that experience with the other similarly funded counseling and testing centers through the same health department program in the community. And the emergency department did about as well as those counseling and testing sites. And even in the early days with a fairly small program, that single ED was contributing about 25% of all the publicly funded testing in that area. So then we looked to see if we were diagnosing patients early in their disease course. Now obviously we were diagnosing them earlier than they would otherwise have been diagnosed, but we wanted to begin to put some numbers to that. And we were disheartened, I think, at the time to see that our median CD4 count was actually fairly low, more in the range of 200 or so. So, but we did learn some things then, and I think over time that place that in context. The first is that the median doesn't really tell the whole story. As you'd expect, it's really more of almost a bimodal distribution where you've got the late diagnosis among the people who are in the ED and are sick, but then you've got ultra early diagnosis among people who are there for some other reason. The second is that when you first begin to screen a population that's relatively unscreened, a lot of what you detect is prevalent disease that's been around for a long time, and so it may be fairly advanced. But then over time, you gradually shift to detecting more newly incident disease that's early. And that's not been very well described, but it's certainly something we've seen. So in 2007, a few years later, we reported what was then novel in emergency medicine circles, which is the idea that it's not just about people with undiagnosed infection, but also those with known infection who are out of care. That's a very hard group to help, but you can make a difference when you try. And certainly the ED is a very good place to find the folks who are out of care for any illness because they're there specifically because they're not getting care elsewhere a lot of times. So about that time, we also became very interested in whether we should be focused on first-time testing among those that might have lower risk or repeat testing among those that have higher risk because we didn't have resources to test everybody. And so the question was, what would be most useful? And the answer is you really need to do both. But in the process, we also found some interesting things, which is that repeat visitation to the emergency department makes it all much more like a clinic than you might have imagined. Over a 10-year time horizon, maybe only 20% of your patients are truly people you've never seen before. And it turns out that you can make progress over time. So even if you're not able to test everyone immediately day one, you might get another chance. And over time, you eventually make progress in screening the population. And that started to spur us to think about overlap between different emergency departments or how EDs might differ. So we used 3 EDs that were within 20 miles of each other and happened to be in the same hospital system to show that most EDs, at least in urban areas, should probably be screening. It's not just the county hospital or the large academic centers. For a couple of reasons. One, the overlap between the ED population isn't as much as you might think it is. And then secondly, even in EDs with fairly affluent patient populations, there's a lesser but non-negligible rate of missed opportunities for earlier diagnosis. And so probably the biggest question and amount of work has centered on this idea of who should we be testing. And I won't go into details now, we don't have time, but I'll just say that it isn't as simple a question as you might think. Despite the CDC guidelines, and we all agree that ideally everyone would be screened, in real life, it's not that straightforward. In this work, we've learned some key lessons. One is that this is a really hard question to study. Another is that when you're screening in a non-targeted fashion, so not targeting those at high risk, the yields are fairly low. They're higher than the CDC threshold for testing, but fairly low even in high prevalence areas. And no ED has, despite some EDs maybe testing tens of thousands of patients every year, no one has succeeded in full implementation of non-targeted screening to the point at which it becomes universal. And in fact, I'll just note anecdotally that most EDs, even those with screening programs, still have a long way to go just in basic diagnostic testing. So a physician seeing a patient who has signs and symptoms of HIV and recognizing that in trying to diagnose that patient's complaints that an HIV test is needed. So not screening, just medical care. If you were going to test using a risk-targeted approach, there's still some questions about how you do that. We all know the risk factors for HIV, But knowing which you assess, how you go about it, how often you do it, how you balance those questions in context with other trade-offs in a large-scale screening program is really fairly unexplored. And I would say that in the view of at least some of us, we feel we don't really know the degree yet to which risk-targeted fails because the screening criteria are insufficient, or is it because the screening criteria weren't fully implemented? And so without understanding that, it's hard to make much comment on targeted screening. Along the way, we learned that, and I'd say somewhat by accident with the advent of fourth generation testing, but we learned that maybe the most important role in the ED is identifying acute HIV infection. So it turns out that maybe somewhere between 1/4 and 1/2 of all patients diagnosed with HIV actually have acute HIV. And this raises some interesting and I think unresolved questions about what do you do next? Do we just keep pushing universal screening and using fourth generation assays and figure we'll find the acute infections that way? Or do we need to develop an approach that more specifically addresses acute infection in some way? Another way to improve early diagnosis is by targeting transmission networks. So in this study, we involved the social contacts and partners of high-risk and HIV-positive patients in the ED. We had them refer their social contacts for testing. If they had companions present with them in the ED, we would offer testing. And then we tried to combine all this with health department partner testing services. That component wasn't very successful, but I think it was important that we noted that it was conceptually aligned. In that work, we had 482 tested individuals with 5 positive, and 383 of them had not been tested by the ED screening program in the last 5 years. Many of them hadn't even been seen by the ED in the last 5 years. So it was a way to use the ED to access a similar population, but one that we weren't otherwise seeing. And finally, I think we have to acknowledge that all the operational and administrative aspects of a screening program have to occur in context with overall ED operations. And it's interesting that cost modeling has been framed more from the perspective of society and the HIV component, but it really hasn't considered the opportunity cost for the ED. In other words, what is it that we're not doing because we're doing this other thing? And there's so many possible approaches to screening and so many variables that it's going to be really hard to ever get at those questions in prospective studies. So we tried to get at this with computer simulation. And I'll tell you that trying to encapsulate all this complexity in a computer model isn't very easy either. But we have learned a lot. And I think we're close to publishing some key lessons, or at least have shown the utility of this simulation methodology for this particular application and arguably other conditions as well. And with that, I'll ever so briefly remind that we also have a parallel story occurring in substance use disorder, opioid use disorder. And we could have a great time doing a very similar presentation in that focus area as well. In many ways, it's a very similar story. Not only do the populations overlap, but a lot of the questions and challenges and methods of intervening overlap as well. I'll take this opportunity to just make one editorial note to say that among these studies was a large NIDA CTN funded study of SBIRT in the ED, which was very large, very expensive, and I think has largely shut down the idea of SBIRT in the ED for substance use disorder. And I think there are a lot of unanswered questions and problems with that trial. And my hope is that we can eventually resurrect some of the SBIRT story in the ED setting. So, but what about combining the two? So as I mentioned initially, I don't think we're very far along on that yet, but certainly a good foundation. And we've got chocolate and peanut butter. We could start putting them together. And I think we do need to make some progress. So by way of example, I'll note a few projects we've been involved in. The first was a review of our ED's contribution to a surveillance system and local HIV outbreak detection. So And the one of the several outbreaks now that's been described occurred in the Cincinnati area and was driven in large part by injection drug use. Prior to that point, we had never had an HIV injection drug use problem, but then we did. In this report, we found that the ED contributed 20% of the overall regional cases identified. And in that program, the number of HIV diagnoses related to IDU grew from 1 per year to 18 per year in just a couple of years, so pretty dramatic. We've also been funded by SAMHSA for a program in which we're screening individuals for substance use disorder and linking them to treatment in the effort to prevent HIV and hepatitis C, and even co-located an infectious diseases physician in the substance use treatment center. And then finally, there's the study we completed as a secondary analysis of data from Project ED Health, which was led by Yale and the NIDA CTN. I'd be the first to admit that this was not a methodologically rigorous study, but I think the findings are actually potentially profound and important for moving the field forward. What we found was that even in the participating academic centers, several of which had long been leaders in the charge for ED, HIV, and hepatitis C screening, most of the patients with opioid use disorder weren't tested for HIV and hepatitis C. And there might be some explanations for that, but still it was surprising how low the rates of testing were. And so there's a couple of ways you can take that. The first is that if you were doing non-targeted screening of everybody like you were supposed to, and it was all fully implemented, then you'd get all the high-risk people. They'd just be naturally swept up in that. But we certainly, and that's a valid view, a universal screening is certainly the goal, but it's not clear if we're ever going to get to 100% implementation. And it's been 20 years, and even these leading centers haven't gotten there yet. So instead, we use this paper to issue a call for a new program of research in hybrid approaches, arguing that we need to develop ways to have fail-safe, risk-targeted screening for those at the highest risk that helps complement whenever your underlying program of non-targeted screening has misses and it doesn't work as intended, and that the two need to be working together. How to do, again, that's a fairly new idea. It's one we've been talking about for a few years, but in terms of an evidence base, it's a fairly new idea. But previous to this, it's been framed more as an either or. So again, thank you so much for the opportunity to be with you, and certainly welcome more discussion.
Thank you so much, Mike. Terrific talks this morning. Jamie, I see you have a question in the chat. I don't know if you're in a position to unmute yourself and if you want to ask directly.
Sure, thanks. And great talk, Nick, great to hear your work. I was just wondering about HIV testing consent requirements and if that's, been a barrier to wider spread HIV testing in the ED, knowing, understandably testing consent requirements kind of vary a lot state to state, but just wondering if that came up in your research at all.
Yes, it's a great question and a great point. And it has been a barrier over time in variable ways in variable places. There's a lot that can be said about it. I don't think it's been really a subject of research per se. I'll editorialize and say that although I'm not a lawyer, my view of the HIV consent laws is that they're really problematic, not just because of what they intend to do, but because they're often written in ambiguous ways that are difficult to interpret, and risk-averse hospital lawyers sometimes are ultra conservative with this. By and large, I would say that the emergency physicians have not been ultra conservative and sort of just take a sideways view and kind of move on through that. And it might be a interesting question whether everything that happens is always legally compliant or not, depending on whose view it is. That being said, there have been surprisingly few complaints. There are some centers where the testing occurs almost by protocol, and although theoretically the patient is aware it's happening, they might not be totally aware it's happening. But even there haven't been many complaints. So yes, it's an issue, and and an important one, but I don't think it's the main barrier that we face overall.
Thanks, Mike, and just applause for both of these great presentations in the chat. So I totally agree, and I think it's really exciting to think about how you're both addressing different conditions and thinking about how do you reach your patients for what they need, right? So with Mike Copenhaver's work addressing cognitive dysfunction in the setting of HIV prevention among individuals accessing treatment for opioid use disorder, and then in the emergency department thinking about both HIV prevention and treatment and addressing opioid use disorder, where people are showing up for whatever reason, right? In these complex environments and so many competing demands. So really just fabulous work all the way around. I had one question for Mike Lyons. I was just curious, and I know you didn't get into this in the interest of time, but I'm going to ask anyway. Is this issue of thinking about individuals who test negative, but maybe coming in for new syphilis, if there's any, what kind of work you're involved with to promote PrEP initiation and use that as an opportunity?
Right.
Again, with all the competing demands and that you have patients who are crashing right next door and all of that.
Right. I'll certainly comment on PrEP. And did you say something about syphilis as well? Did I mishear
so
that?
say they come in for their evidence of high risk, right? So either because of known substance use or because of, an STI, whatever. They test negative for HIV. Is there any, is there any work that you're involved with right now around implementing PrEP at that time, or at least facilitating a conversation?
Right. I would say two key next areas are about STI in general, which is, obviously a very common and important problem. It just hasn't been funded in the same way and supported in the same way, but it's, I think, around the country, driven in part by the syphilis epidemic, we're realizing this is all one thing. Certainly, you would imagine that if you're seeing someone for STI, at least at a minimum, you should be testing for HIV, and that's a strategy that's being discussed as well. What do you do with the folks that are not at risk but not HIV positive? Certainly, for some time now, the focus has been on testing and not bogging down the testing with prevention counseling. We always had a culture of prevention counseling, and I still wonder about if there's not some role for some type of a primary prevention, behavioral intervention in the ED setting. Apart from that, for biomedical prevention, PrEP is obviously a huge issue, and people are talking about it in great detail now. There's some places that have experimented with it. There's a couple R01s funded, a couple K grants that are in preparation. So I think we'll be starting on that. I wonder how fast it will go. I hope quickly, but I wonder if it's maybe back where we were 20 years ago with the screening. There's a lot of tough questions that you wouldn't initially anticipate, not just on the obvious stuff about how do you get it done and the resources and get it implemented and all of that, but how does it intersect with the testing part, right? Like, is it that if you're doing non-targeted screening, and then your trigger is that the HIV test is negative, and now you want to talk to them about PrEP. Well, you don't have any risk information to know who to talk about, right? So there's this weird intersection between the testing program model and the PrEP part, and then how you operationalize that is only now being discussed. But ultimately, I mean, I think it's obvious that there are high-risk patients known in the ED who are not getting PrEP otherwise, where it would be nice to try to do something about that.
Yeah, thank you. Dr. Rod, I see you have your hand up.
Yes, I do. Thank you. And thank you to both speakers, both Michaels, by the way, as well. So these are topics that are sort of high interest to me. I run a PrEP program for the hospital. And so that's why I wanted to know much about, when you talk about providers, who are you approaching? Because it's not something that people want to simply they're not willing to participate as eagerly as you think. And that includes people in the emergency department. So Jen wanted me to share with you a little bit of an experience, and I won't take up much time because there's a few minutes left. So we did a pilot program at the Yale New Haven Hospital ED department, where we used a screen to look at high-risk behavior, which meant STI testing. And that was low acuity and a good opportunity to provide information to the patients that PrEP was available. And that was the use of the PrEP navigator to get them to the clinic, except that the navigator was the nurse who got the results also, because if they were positive, then they needed to be immediately linked into care. And I won't go into detail, but there were many things that were not very easy to overcome in terms of barriers. But one of the biggest ones was buy-in from the ED, including administratively. So there also happens to be an RFP out for the state right now to look at this actual HIV testing sort of paradigm and what we could do for PrEP. So just advice as to what you think ED administrators want reassurance with. We told them we would take care of the positives. That was an easy thing. But how do you get them to buy in to do the testing? And we took it a little one step further. We actually went to the legislature and we passed a bill last year that now mandates that the ED offer HIV testing in Connecticut starting in January of 2024. So, and not a surprise, they were the biggest group that was against this bill. So just want to see what your thoughts are in terms of buy-in from ED admin.
So this is why I wanted to take some time in the early part of the talk and just talk about emergency departments, because, you know, this is the reality, right? And so of course we could talk for days about this. I guess my main message would be, I don't think it's a one size fits all. I think, and I don't have the perfect answer, but I think you need to get into the head, if possible, of each and every administrator and figure out what their real worries are. And oftentimes what they're saying is not what they're really worried about. You know, they haven't thought in detail about it to really dissect their own views. They're just, you know, not up for it. Typically, it has more to do with, at the administrative level, fear that their rank and file folks won't go along, a core belief that it's not their job, or a belief that they just don't have the capacity to do it, or that they should be given resources to do it that they're not being given. And it's usually some combination in there, and the solution is usually something about saying, okay, fine, we won't do this and we won't do that, but could we just do this? And getting some type of a gateway drug, you know, do something one time and then 2 times and then 5 times and just gradually whittle away at it. The CDC wanted, you know, in testing, they wanted everybody tested, the big thing, and then see what you get. And I think the problem with that is that you have people say, well, I can't do everything, so I won't do anything. I think you have to put it incremental and reverse it and say, I know you can't do everything. I'm just asking you to do something. What can we do?
Well, I'm cognizant of, oh, sorry. Thank you all. Such terrific presentations. I know we could probably talk for another hour, but I want to be cognizant of the time. Just remind everybody that as you close your Zoom, there's going to be a pop-up for a survey to please do that to provide your feedback. And again, thank you very much to our speakers and to Dini and Pete for seamlessly organizing this. And I know this will inspire lots of conversation, potentially future collaboration. So thank you very much.
Thanks
Take care, everybody.
us.
Thank you very much.
Thank you, everybody.